Hi, everyone, and welcome to this e-Impulse Rebeat.
Sarah, our last episode on Trank Dope when you interviewed Dr. Han Nguyen was super interesting. I seriously couldn't believe how much fentanyl in Philadelphia is contaminated with xylazine. That is insane!
I know, and that New York Times article and discussion with Han was really helpful. I still haven't seen a patient that I think has used Trank Dope or contaminated opioids, but I'm ready to consider higher doses of naloxone if needed for respiratory depression. And I will have a higher clinical suspicion for xylazine contamination in patients presenting with complicated wounds.
We have podcasted on opioid use disorder and medication-assisted treatment several times. This is a topic near and dear to our hearts.
In fact, our 4th episode ever was The Game Has Changed, which features a powerful story of a patient with opioid use disorder, sharing her own story and her son's.
Our guest was Dr. Gail D'Onofrio, professor of emergency medicine and chronic disease epidemiology and internal medicine. She is core faculty of addiction medicine at Yale. It also features our former colleague, emergency medicine physician, Dr. Josh Elder.
We want to rebeat that episode for you again, but there are some important changes. So we took out the portions about the X waiver, and we will have an update for you with Dr. Amy Moulin in our next episode.
These are exciting changes in the world of medication-assisted treatment, or MAT.
Okay, let's jump into the interview from 2018.
Well, good morning, and my name is Rachel, and I'm here to hopefully share some of my experience, strength, and hope to assist people in this epidemic. My story started off as a young girl who was bullied and was molested as a child. And I hid that because of my pride, and it was such a big secret. I am a sufferer of migraines, and I was 16 years old, and my father had taken me to the emergency, and they had given me an opiate. And when I took that opiate, I'll never forget it, that this was exactly what I was looking for. And it felt like these two arms, and it was like someone that was comforting and empathetic and safe put their arms around me, and that was that. And I knew I had to have that. This is what I needed for the rest of my life. My life revolved around chaos, vulnerability, sickness, rape over and over and over again. I became immune to that. I was savagely beaten and raped, trying to make money for my medicine. And I ended in the hospital, a trauma unit. I had stitches in my head. I had a broken teeth. I was full of bruises. And as soon as that went away, I was back on the street because that's how powerful it is. I look back until I was in my early 20s, and my mother finally coaxed me into the car. I couldn't get into her car before. She would come looking for me, and I wouldn't, and I couldn't get into her car. But this time I trusted her, and she said, I'm taking you to the hospital, and they're going to help you. And I got into her car thinking, I'm with my mom, I'm in her car, and someone's going to help me, and they're going to put me in a hospital because I'm ready to get off these streets. I don't want to live my life like this anymore. I don't want to be on the streets in the rain. I don't want to do this. I don't want to see my friends dying. I want some help, and maybe I can become that veterinarian, and maybe I can become that nurse. And I got into the car with her, and I remember waiting hours with her, and I'm in this detox. They finally took me back, and they turned us away because I was just a little junkie, and this was part of it, and this is what I had to do and go through this pain. Now, let's go back to what the pain is like. If anyone's ever had an abscessed tooth, that's what it is. And you're full of anxiety, and you're full of the trauma, and you're full of what you did and the guilt and the shame and all of that into one thing, that you're a young girl and you don't have the coping skills, and you are damaged goods. And this is what you're supposed to be. That's where I was at. So you go right back to the heroin, right back there, because you think you belong.
Can you tell us a little bit about your experiences with the medical community when you were coming in for abscesses or after being beaten or things like that? What kind of experience did you have in the emergency room or urgent care, wherever you were?
At that time, maybe people weren't equipped. Okay, I had so many, there was layers and layers and layers of what it is to be a heroin addict. There's the trauma. There's the positive TB test. There's all these things that when you come in with, as a patient, what are you going to do with me? How are you going to place me? Where are you going to take me? Maybe I'm on methadone. This place doesn't take someone on methadone. I think that what happens is the stigmatization of knowing that, is that even that the right word? Knowing that I'm a heroin addict and that she's just a junkie. This is her life. She chose to do this. Well, I don't have a choice at that time because my brain is different. Okay, I don't have a choice. I don't have a choice, and that's called addiction.
Can you tell us a little bit more about how you finally decided that this was the time to get clean and how that finally happened and what changed and made it different that time?
I was in a crack house, and there was another girl who knew me, and she was in a sober living. She had told someone about me, and who was a woman whose name was Janelle, who took in women who fell through the cracks. And this was far away from Oakland, and I got a phone call in the crack house. And it was a woman saying, "Honey, do you want some help?" I said, "I thought no one could help me." She goes, "I can. I have a place that you can go. You can come to." And for some reason, I trusted this female again. I just trusted that this could work for me. And she took me in, and she ran sober livings. They put me on the methadone clinic, and we light our way into a treatment program. They showed mercy on me, and I came off the methadone. But however, when I came off the methadone, I only stopped at 10 milligrams. So I kicked again, and it was horrific. But mind you, I had a little boy, and I was too weak to get out of the bed. I was too in pain, and I decided to get clean.
That's amazing.
Now, Rachel, you now work as a substance abuse counselor, right?
Absolutely.
How do you think addiction has changed? How do you think opportunities to get clean, or the opportunities to get drugs and then the opportunities to get clean, how has stuff changed now?
The game has changed. I've been in my field for some years now, and I remember us saying, no, the girl's got to kick, the girl's got to do this, go through the withdrawal so she can learn a lesson or what have you, but that's always been in the back of my mind. That doesn't work. The game has changed. This epidemic has flooded suburbia. You do not need to be in the Tenderloin. You do not need to be in the cities and the concrete to obtain this drug. The game has changed with Suboxone. But the main ingredient, I think, is hands-on. It's like having a snake bite. You have this snake bite. You go into emergency. You know there's an antidote. But what if someone says, maybe they're not that, we don't have that antidote, or maybe they're not that candidate. And you go home with this snake bite that can fester and you can die from. It needs to be right there, because with someone with the addiction changes their mind like this, because you're in so much pain, all these things are flooding through your mind. You have to have this drug. And we're losing a generation of children. My own flesh and blood, my own child, this little boy I have, started using because it was available. And the Oxycontins and this and that and pills and what have you, and seeing the decline in my own child and knowing what was ahead of him. I have gone into hotel rooms, knocking on doors, looking for him, asking the prostitutes on the street, have you seen this boy? Knowing that he could die. People opening up the doors and seeing these young people in there in packs. And the smells, and I know what that smell of infection, that bacterial sweet is, and looking for my own son because I know he's in those hotels somewhere. And kidding him and saying, Mommy can help you. I'm taking you somewhere. And we're going to help you. We're going to help you because I know this is available, and being turned away. and sitting there like my own mother did and being let down. And it feels like your stomach just falls through you. All the hope disappears. What do we do for my child? This is not a fever I can tend to. This is not something he has a broken leg and he can go into surgery and we'll take care of this. This is not that. This is something much different. And being enmeshed with your own child and knowing that child could die, because that's the end result. The bottom is death. That's the bottom. And now someone showed mercy on him and he was able to obtain the Suboxone. And this was a couple of years ago. And in this time that my child was able to take the Suboxone, his best friend, this child that I had in my car, looking in back of me and seeing this wild blonde hair bouncing back and forth to the music, OD'd and died. My child has been on the Suboxone, has been able to go through a program and stay in a program, get jobs, has his own little place with a beautiful, beautiful girlfriend, and is living a life because of Suboxone. Because of Suboxone. The game has changed. We are seeing a generation of children that are dying from this because of the availability of this drug. These children are not equipped to be on the street. I am so pro methadone, but I'm so pro the Suboxone right there, and knowing that this can work. And I'm not saying it's going to work for everybody, but if we can just help one, like my own child, we can help so many.
So with your clients now, do you see a lot of people on Suboxone?
Yes, I do.
Yeah. When you see that compared to methadone, how do they compare? Is it a different thing? What do you see from that end?
I see a light because I was asleep for my own self for 13 years. I see a light. The lights are on with the Suboxone. They're laughing. They're talking. They're happy. With the methadone, something's asleep. With the Suboxone, you can tell there's a light. Someone's awake. There's hope. With the methadone, it's a little bit different.
Do you think the stigma is different between people that are on methadone versus Suboxone?
Yes, I do. Years ago, we knew there was doctors that can give us the Suboxone, but it was out of our reach. We knew there was the gift out there. We call it the gift. We knew it was out there, but how are we going to obtain this money and go to Sonora and get this Suboxone from this certain doctor? And it's still that way with certain doctors could prescribe this medication. Okay, so we have to figure it out. And how can they do this? And how can we obtain that? With the methadone clinic, you can get on the methadone clinic. And what happens is you get wrapped up. When I was sick and I go, okay, I relapsed, I'm sick, I know where to go is with the methadone clinic. And I can obtain anything I wanted. And what we do is that we take a secondary drug or a third drug, like we chew up some Klonopin or we chew up the Valium to get that little more nod in there. And then I want to come up, so I want to smoke some crack. And so you just go to the methadone clinic, go get some coffee, you're loaded again.
Wow.
I lived it.
Yeah.
I lived it. With the Suboxone, you see this different kind of life. They're doing things, they're concentrating. What I'm not doing is putting people down that are on methadone, because I was on it for years and years.
Yeah.
I saw it work for certain categories. But what happens with it is that you get to this level that you feel like you don't want to do anything. You're asleep, and all this trauma and all this depression comes along with it. It's a depressant. You're depressed.
What would you like doctors to know about that child that's being brought in, overdosed, or looking for help? What would you like medical professionals to know?
That it could be your child. And even though we see the children that have these track marks or their teeth are rotten, they once were someone's baby. It can be anyone's child, anybody's child. And if you don't know someone, yeah, you do. You do now, because it was my child and I was someone's child. And all of us once were children.
like in our human trafficking discussion a few months ago, Rachel didn't get help the first time she was seen by a provider. It was over time and with people providing safe and loving relationships. That's trauma-informed care. Providing that safe place and having the right tools for when they want to get help at that right time. Okay, before we get started, Gail, help me out here. How can we frame this in a way that people like Rachel are not stigmatized so that they feel comfortable having this discussion in our emergency department?
So in order to decrease stigma and get people into treatment, because that's the number one reason people don't go into treatment is because they're stigmatized about it, is that we use the right words. So even though that's really hard, the words are really that someone has an opiate use disorder or they have an addiction and that they aren't, quote, addicts. We don't say that diabetic over there. We don't define people by their illness. We also try not to talk about clean and dirty urine since we don't talk about if you have glucose in the urine, whether it's clean or dirty. So we say that it's a positive urine or it's a negative urine. That we don't say it's a problem, again, that it's a disease. That we don't say that we relapse so much as that we are in, remission or we're in recovery, So all these words are really important. They're not babies who are addicts because babies can't be addicts. They have abstinence syndromes. And so if we treat it like a disease, a chronic relapsing disease, then people will understand it more and people will be less stigmatized. So words matter, accurate words matter, and we can be part of making that happen.
Back in 2015, you published a large study in JAMA that was called the Emergency Department Initiated Buprenorphine Naloxone Treatment for Opioid Dependence, a randomized clinical trial. This randomized clinical trial compared three different things. You screened with a brief intervention and then ED-initiated treatment of buprenorphine naloxone. And then you had them follow up in a primary care clinic for 10 weeks treatment. The second intervention was screening with a brief intervention where you kind of talked to them about readiness and facilitated a referral to community-based treatment services, helped them contact that facility. And then the third one was screening and then just given a list of treatment options or referrals out in the community. So you found in that third group, in the buprenorphine, naloxone, and referral treatment group, that there was significantly increased engagement in addiction treatment, decreased 7-day self-reported use of opiates, and decreased use of inpatient addiction services on the short term. And this foundational paper established not only is buprenorphine and naloxone treatment in the ED feasible, but it has better outcomes than simple referral or referral and a brief intervention. One of the more recent papers that you published, Gail, was addressing the cost effectiveness of this treatment of bup treatment in the ED. And I thought it was really interesting that you found the types of treatments received following ED discharge differed considerably by treatment group. So there was more benefits in the ED-initiated treatment with bup and slightly less healthcare costs. And I think that's very important in the grand picture of things.
It is. So that analysis was done by Susan Busch, who's a professor of economics, really, and health economics. And I could not begin to explain how she did this analysis. But the important thing to note is that patients in the buprenorphine arm who had 2 times more success in getting into a formal addiction treatment at 30 days, that those patients were outpatients primarily. And as an outpatient, they would still see a doctor a couple of times a week, but that's much less than it is to getting an inpatient bed. And so we often say for opiate addiction that we need more chairs, we don't need more beds, because we can do this with less costs, but it doesn't mean that it's less utilization because they'll be seeing a doctor fairly routine until they get into a stable dosing regimen. But we found that at any willingness to pay, no matter what you chose, from a neutral area to anything else, that buprenorphine was more cost effective. And it also showed that for a decrease in 1 day of illicit opiate use, that we were also cost effective. So that was good news. And that was only healthcare costs. It doesn't take into all the other costs that could be associated, less crime and, less incarceration, et cetera.
Yeah, that's amazing. What is your perspective on how the ED provider plays a role in this national crisis and how can we help with it?
So I think that emergency physicians, are great problem solvers. if we couldn't work where we are, right?
Yeah.
I mean, we do life and death all the time. So we pretty much are a high risk group of people. And I think most emergency physicians are into their communities. And since the ED is the front door of their community, they are interested in helping what's going on. We're also a group that tell me the algorithm, tell me it's evidence-based, and if you can make it easy enough for me to do, I'll do it, right?
Yeah.
And I really don't think that you have to change anybody's attitudes about something. I don't think you have to, because you're not going to. I don't think it's necessary. And as I say all the time, we don't ask people what their attitudes are about giving a tetanus shot. Do you happen to like that idea? Even though we've never seen a case of tetanus, we give it. 50 million people ask questions about tetanus. You can't get out of there without a tetanus shot if you're injured. So why couldn't we normalize addiction similarly and really treat it like any other chronic disease or any exacerbation of a chronic disease? And let's get moving.
So along those lines, let's get practical about this.
Okay.
So how do you screen for opiate use disorder in the ED? How do you identify willingness to change? How do you even make patients comfortable talking about this and sort of reducing the stigma?
So we'll start first with screening, okay? So a lot of people get scared by that because we got to screen for a lot of things. Who's going to screen? And you've all been in trauma rooms that, the American College of Surgery requires you as a level 1 trauma, and the nurse goes, "You don't drink, do you? Do you live in a safe place?" Well, I really don't know. My dog died last week, so I don't live in a safe place. So the way I feel about that is screening for opiate use disorder is not easy. Just start with the people in front of you. They're either coming in with abscesses, they're coming in with other soft tissue injuries, they're coming in with overdoses, they're coming in seeking help. In our study, a third of people were seeking help. About 10% were overdoses, and the rest were found by screening. But it's only a small group of people where you really have to know how to screen well, because people are not going to come out and just say, "Oh, yeah, I happen to use a whole lot of Percocet." We do know some questions that we found that were helpful. If people said, "Do you use any of these lists here of drugs that are opiates?" And if they said they used something, then we would ask them, do they have to take more than they were prescribed? Did they've been using it more than they thought they would have to do? Did they have any concerns about it? And that might open up some conversations. But quite truthfully, if we just start with the people that are right there in front of us, that would be a great change. That's the first step. The second is that you asked me about the conversation. So we have developed and tested this thing called the brief negotiation interview. It has 4 components. The first component is just introducing yourself if you haven't already and bringing up the subject. The second is giving them feedback. So you'd say, "Hi, I'm Dr. D'Onofrio. I'm going to be taking care of you today. I understand that you are here because of this abscess in your arm and that you're using heroin." And they'll talk about it. In that case, you might ask them how much are they using, but it's not that important. They're injecting heroin. You ask them how comfortable that they are right then, because if they're in withdrawal, it's not a good time to having this conversation. You may, in that times of feedback, give them some information. "Well, we're here to help you. We do have some treatments that could be available to you." And you can ask a few questions regarding, are they in treatment already? Have they ever been in treatment or whatever? And then from there, you move right on to enhancing motivation. And that is once you've had that conversation about, "I think we could help you here. We know that you're using 3 or 4 times a day. I'm concerned about you that you could overdose. On a scale of 1 to 10, how likely are you to want to accept some treatment here today?" And most people will pick in the middle, and you'll say, "Okay, so you chose a 3. Well, you're 30% ready to accept that treatment. Can we talk about what were some of the reasons why you didn't choose a lower number?" Meaning there are reasons to change. So they'll come right out and tell you things. "Cost a lot of money, lost my home." So you reiterate that back. It's a little of motivational enhancement. And then you say, "Okay, so it sounds like this has been a really difficult time for you. How about we start something right now?" Then you just decide what next steps are and you do it. You could imagine if I approached a patient, particularly after overdose or at any other time, and say, "So, you want to get some treatment? Or what do you want now? You're going to die tomorrow if we don't do this," that wouldn't go very well. So it's just a matter of simply really just starting a conversation. There are many patients who will not want to change and will not want treatment, and you're not there to convince them to say what you want them to say. You're there to say, I hear what you're saying. I would like you to do this because blah, blah, blah. But we can agree not to do that at this time.
How long does having that discussion take you on average?
So in the study, we actually timed it, and that was less than 10 minutes. But in real life, it's really less than 5 minutes. And it's really no more time than you would really spend with a person. And you can be doing it while you're doing if you have a procedure with the patient, you can be talking to them about it. You can do it at any time. A nurse could do it. A counselor could do it. It's really not that hard to do it.
Yeah, it seems like a fairly simple team-based intervention that could reduce visits in the future and help get these patients to a healthier spot overall.
Yeah. And so then what's the next step? So they say, okay, I'm willing, I'm interested. What happens next?
Okay, so then we have a protocol. And the protocol is, first of all, the most important thing is that you have to know that this person has an opiate use disorder, right? So there are people who present to EDs with overdose or other things who are experimenting. And you don't want to start someone on a chronic opioid that's experimenting. So, and an adolescent that's just getting started, someone that's really only been on opiates for a month and got into trouble. It's not something that you want to do. It's also, you have to know the criteria for opiate use disorder so that it differentiates from patients who are dependent on the medication and tolerant because they've been prescribed it. But they're not doing this unusual behavior. They're not spending all their time trying to find it. They're not buying it off the street. There's not all these behaviors that are associated with addiction and are clearly written out in the DSM criteria. So first of all, you have to be sure. Now, that can be very complicated for some patients and may put people off. But again, if someone's coming in and they're shooting 5 bags of heroin a day, you don't need to go through all that, all right? They have an opiate use disorder, so stick with it. So on those patients, once you know that you have someone with an opiate use disorder, and we also require that we have a positive urine for opioids. That's how people are not coming in here telling you everything that you want to know so they can go sell it, right? Literally. So they have to have a positive urine. They have to meet criteria for opiate use disorder. Then in terms of whether or not you provide a dose in the ED is whether or not they are withdrawing or not. The only bad thing you can do with Suboxone or buprenorphine is give it to someone who is not in withdrawal, who has other long-acting opiates on board, because buprenorphine has an incredibly high affinity to the mu receptors. It will bounce everything else off of that. So if you've taken methadone and you don't tell me that, and you come in and you're slightly withdrawing and I give you this, I'm going to put you in full-blown withdrawal. And it's the most worst thing you can ever imagine. So based on the history, based on the fact you think they have an opiate use disorder and their COW score, you can administer a dose. So in our study, if people were in sort of the end of mild to moderate, we would dose them with 8 milligrams of buprenorphine. It's miraculous. All you have to do is see one person in acute withdrawal and come back in 30 minutes and they're like normal.
Wow.
So you'll see them off the wall and then you'll come back and go, oh my God. And now you can continue the conversation. In the point where you think, I cannot give it because they're not in withdrawal at all, we did take homes. Then we follow them up. We're very lucky in New Haven because we have 4 or 5 different agencies that will take our patients the next day, if not on Friday, by Monday. Buprenorphine is a long-acting opioid, by the way. So if you dosed it highly on one day and they couldn't get in for 2 days, you'd probably be perfectly fine.
So this is really best done multidisciplinary. You really are dependent upon having a place for these people to go as an outpatient basis and then pass that baton on.
Absolutely.
How did you establish that? How did you find those connections?
So as part of the study, we did it all with primary care. And David Fiellin literally saw every patient. And that was maybe a contributor of the success. People like to go to primary care settings because they're sitting in the office with everybody else with chronic diseases or other acute illnesses. They're not stigmatized by standing in line in an opiate treatment program. And also, they get stabilized fairly quickly. So they might be seen a couple of times the first week, but then they can get weekly doses and then even monthly doses. So it works out. People can keep their jobs. No one needs to know why I'm there, etc. Whereas if you go to an opiate treatment program, it's much more difficult. You have to go every single day. You have to go for a long period of time before you can get take-homes. It's much more invasive on people's personal lives.
Yeah, I love the idea of what you said at the beginning about looking for more chairs, not beds.
Is there anything else that you think is important for ED providers to know in terms of maybe initiating something like this where they are?
The only other thing is I would say when I started out as a resident, we never treated chronic disease. We referred it all, and that was high blood pressure or, we admitted people with new diabetes. We don't do that anymore, right? So we very frequently initiate hypertensive medications in the ED and refer. We very frequently start people on hyperglycemic agents and refer and do a very warm handout. So there's really no reason to believe why we shouldn't treat this any differently. And especially since there's so many people dying. And we need to step up to the plate and not have excuses of why we can't do it, but how can we do it? And how can we partner with our community? And how can we, really influence and really improve the health of our public?
Josh, we talked about a really well-run, slick operation initiating buprenorphine naloxone treatment at Yale. And I know you trained there and got to see it at work. So tell us about the project that you're getting going here at UC Davis and how you're using that.
Thanks for asking. It's really a collaboration. Having seen what's possible there, we're, really putting together our work group to think through how we can incorporate some of those solutions here at UC Davis. And the solutions are really focused on screening. So, trying to get patients the help they need when they come to us. Narcan distribution, getting Narcan to the folks that need it. And medication-assisted treatment. There are a lot of people coming through our doors that we could really leverage our connection to the community to help people in need.
And what made you decide to get this started?
Yeah, that's a really great question. I have always been passionate about innovation and health policy, and in particular the opioid epidemic. I think we have a real opportunity to take some of those lessons learned and some of those exposures I saw firsthand and try to implement them here to help our community.
And as you start to roll this out, what kind of feedback or what kind of pushback are you getting from doctors? What kind of responses are you hearing?
I've heard this quote that, medicine is nothing more than politics on a small scale. And it's so true. A lot of the work we attempt to do in the emergency department can be really politicized and viewed as a politicized framework. And so I think this is a hot button topic for a lot of people, that they say, here are patients that are coming through the emergency department. They're always here. How are my efforts going to change this? And they may have certain views on this about how, we should utilize resources when patients come in with these type of problems. But when you look at the literature and when you look at the humanity of this, it's the right thing to do. And as we develop better algorithms and better ways and better toolkits for emergency physicians, my strong suspicion is culture and practice will change. It's like anything else, door to balloon time, anything that we start to measure, that we start to tell providers, you have to do this. It doesn't matter how you feel about it. You have to do this and depoliticize the work that's important and that's evidence-based. It will change practice, but I think it really is going to require a culture of champions in different areas around the United States. And I'm really excited about the opportunity to kind of take those lessons learned with our work group and try to start inspiring change here at UC Davis.
What kind of barriers have you run into so far, and what advice do you have for someone who might want to get this started at their hospital?
I'd say reach out to us. I think what I've realized is mentorship is the way. Gail D'Onofrio has been so generous with her time and oversight in helping us. And from, the first week I was here, reaching out to her and said, hey, I'd love to get some of these innovative things off the ground, but we have to go back to some of the basics, building blocks. How did you do this? How do I do this? Like nuts and bolts. And taking the time to talk to me and give me feedback and give our work group feedback from protocols to what is being done at other environments, other communities. So a lot of it has to do with mentorship, feeling comfortable. It's no different in my mind than you're practicing or you're doing a chest tube for the first time or you need this oversight. I think that's the biggest challenge, but also the biggest solution is finding that mentorship. So for those that are vocal, like myself and Gail and, Amy, et cetera, reach out to us and we can help kind of, facilitate and show you what we've done so that you can, not have to go through some of those hard battles yourself.
Pulse check.
Today, we have learned firsthand the devastating effects opiates can have in a person's life. We have heard from visionaries like Gail D'Onofrio that are demonstrating that treatment with buprenorphine naloxone is effective And it can and it should be initiated in the emergency department. The game has changed.
Well, that is definitely still relevant to my practice today.
Oh man, Sarah, I wish it was not relevant to my pediatric practice, but sadly it is also.
So join us in our next episode for some very important updates with Dr. Amy Moulin.
And thank you to our department for prioritizing this issue.
And thank you to OM Productions for editing this episode to make sure it is accurate.